Hello friends, today we have this patient who is an 80-year-old male with an underlying interstitial lung disease who had a post-tracheostomy tracheal stenosis. As you can see from the bronchoscopic picture here, there is a presence of a tracheal stenosis just above the tracheostomy port along with evidence of granulation tissue. So initially a cryo extraction of the protruding granulation tissue is being done with the help of a cryoprobe, and as you can see from the video here, multiple passes of cryo extraction are being performed in a guarded manner to avoid any sort of bleeding. Once it is done, now the tracheostomy is removed, and then controlled radial expansion balloon is inserted through the rigid bronchoscopy, and controlled radial expansion of the stenosis is being performed. Once it is done, since the adequate lumen couldn't be established, now mechanical dilation with a rigid bronchoscopy is being performed. As you can see from the video here, serial dilations of the tracheal stenosis with the help of a rigid bronchoscopy is being performed. Care is taken not to injure the tracheal wall and cause the perforation of the tracheal wall. We start with the smaller size rigid barrel, and under controlled manner, subsequent larger sizes of the rigid barrel are introduced to make sure that the stenosis is opened up, and it is done in a very guarded way without causing injury and simultaneously ensuring good ventilation for the patient. Care should be taken not to introduce the rigid bronchoscopy in an angulated manner, which can result in the perforation of either the posterior tracheal wall or even the fracture of the anterior tracheal cartilage. Once it is being done, uh, this helps in achieving an adequate airway lumen. However, in this case, there was not only a tracheal granulation, there was also a significant tracheal stenosis despite having adequate mechanical dilation with a rigid bronchoscopic barrel. So here a decision for insertion of a silicone stent in the form of a Montgomery T tube is being done. So the distal end of the T tube is first inserted, followed by which the proximal end of the tube is inserted overlaying the stenotic area, and this stent is generally left for a period of 6 months to 1 year. In this case, the stent is left for a period of around 6 months. Following 6 months of a Montgomery T tube placement, now you can see that we are removing this Montgomery T tube, and once the T tube is removed, now you can see that there is a near complete recanalization of the proximal tracheal stenosis, and you can see there is a significant dilation of the tracheal stenosis, and there is a near complete recanalization. And once it is achieved, now care is taken to avoid restenosis, and if required, serial dilations are performed. But in this case, we didn't require serial dilations, and after 2 weeks of stenosis dilation, you can see a near complete recovery, and you can see the patient going back to his routine activities, doing all the work by himself. So this is a very successful case of a post-tracheostomy tracheal stenosis managed with a Montgomery T tube placement, and eventually the T tube was